This program is brought to you by Teachers College, Columbia University. Please visit us online at itunes.tc.columbia.edu.
Good afternoon once again. I've had a very good day today. Been to some different sessions, and I hope you had a good time too. We're getting to the end of this first day of the fourth annual Health Disparities Conference, so I hope you've enjoyed it, and I hope this presentation doesn't disappoint you either. Dr. Wallace introduced me, but my name is Charles Olufemi Daramola, and like Dr. Wallace said, I'm an assistant professor of health education at the Borough Manhattan Community College, which is part of the City University of New York. Okay. What I'm going to talk about this afternoon is the research on my doctoral dissertation, and of course, you know, it's hard to get all the research into a 40-minute presentation, so I'm going to try to tease out some of the key things in the presentation and focus a lot on the results of the presentation, and also provide you with some things that if you are involved in any way, shape, or form in working with African Americans who have high blood pressure, who may be at risk, there may be some information for you in this presentation that will help you. It's to answer the "what's in this for me" type question. So the title is an internet survey investigating relationships among medication adherence, health status, and coping experiences with racism and/or oppression among hypertensive African Americans. And if you're trying to wrap your mind around that, just think of medication adherence and coping skills. We'll try to marry them together, and as I go through the presentation, I think it will become a little clearer to you. Okay. As an introduction, I think regardless of race or age, ethnicity, we know that heart disease and stroke are very common, some of the most common cardiovascular diseases in the United States. As a matter of fact, they are the first and third leading causes of death for both men and women in the United States, accounting for more than 35% of all deaths. Now, this number is changing quite rapidly. When I did this research, it was 35%. It may be a little higher now. But heart disease and stroke, major diseases, regardless of race or ethnicity. So, if we look even a little closer to African Americans suffer from a disparate level of cardiovascular disease, including high blood pressure. So cardiovascular disease is a problem for the nation as a whole, but amongst African Americans, it is even more of a grievous problem. The age-adjusted death rate for heart disease per 100,000 was 300.2 for African Americans, compared to 232.3 for all populations, a relative health disparity of 135.3. So what this tells us right off the bat is that African Americans, when it comes to heart disease and high blood pressure, are at a disadvantage. There's something happening that creates a situation where they have more high blood pressure, more cardiovascular disease than the rest of the population. And we'll get into that a little bit. Okay. So now that we've sort of established that cardiovascular disease and high blood pressure is a problem for African Americans, let's go into some more of the information. More information in terms of things that people are working on and ways they're trying to reduce the health disparities and help control cardiovascular disease. One is medication adherence. And medication adherence plays a role in the higher levels of cardiovascular morbidity and mortality experienced by African Americans, and it contributes to health disparities. Just as a background, medication adherence is whatever medication you're given, taking it at the right time, at the right dose, like you're supposed to. That's adherence. Proper adherence to medication has been linked to better health outcomes, and non-adherence has been linked to poor health outcomes, including higher mortality rates and more hospitalization. So if you don't take your medication like you should, poor health outcomes, hospitalization, and poorer health outcomes. So that's one item, medication adherence. Another item in this research is that there are now some emerging theories that racial discrimination may be a contributing factor to the higher levels of high blood pressure diagnosed in African American. So you've heard a lot about why African Americans have high blood pressure. Diet, insurance, geography. But there are some newer theories that seem to suggest that the racial discrimination, the stress from racial discrimination that is experienced by African Americans on a daily basis may also be a factor in creating those high blood pressure numbers. Secondly, the skills utilized to cope with racial discrimination may have an impact on the health of African Americans. So we know that stress and racism may contribute to high blood pressure, but the type of skills utilized by African Americans may mitigate those high blood pressure numbers. As an instance, adaptive coping skills, skills that require you to do things positively, may help reduce your blood pressure as opposed to negatively, which would be maladaptive coping skills, which we'll get into a little bit later. Okay, so we have identified two things. One, medication adherence helps with high blood pressure. Two, the coping skills also help with high blood pressure. So what we try to do with this research is to identify coping strategies associated with medication adherence. So we're trying to marry the two. Coping strategies, medication adherence, what are some of the skills that we need or that some people have that helps them with their medication adherence? And if we know these two things, what we could try to do is form some intervention programs that would increase medication adherence by identifying the type of skills that will increase medication adherence. So, factors associated with high medication adherence might facilitate positive health outcomes for at-risk African Americans. So just a little bit about the study. The study investigated potential relationships between medication adherence, selected demographics like age and gender, health status, and a new set of measures developed by the research group on disparities at Teachers College, Columbia University. Some of the key ones, which we won't get into the details, are perception of racism and or oppression scale, when racism and or oppression happen to me scale, and the coping and responding to racism and or oppression scale. In-depth scales, I can talk to you, individually if you want to know about these scales, or contact the Health Disparities Department. They have these scales, these new scales that you can get some more information on. The methodology, just a brief part about the methodology. I used an online survey through SurveyMonkey, which is a service provider where you can put your questionnaires or your surveys online and have folks respond to your questionnaire online. It focused on hypertensive African Americans, regardless of country of prior birth, and there were laptop computers placed in an adult community health center in Northeast Philadelphia. How we got to this, initially we had gotten a list of African American internet users and got the survey, sent it out to that list. We didn't get a good response from that. So what we wound up doing was locating an adult community health center in Northeast Philadelphia, and those who had computers went home and they were able to respond to the survey. Those who did not have computers, we provided computers at the health center for them to go on and complete the survey that we had available for them. Okay, just some general information about the numbers that we got. We got 189 participants who completed the survey, and 134 that met the inclusion criteria by indicating that they were taking medication for hypertension and answered the medical adherence question. So our final sample was 134. Okay, now here's where I want to spend a little bit of time in terms of the results. We used two things. One was the Morisky Medication Adherence Scale, which is a well-known scale used in the health education field to determine medication adherence. So we had that scale. And then we took some correlations between the Morisky medication adherence scale, and selected demographics, along with a new set of measures developed by the research group on disparities in healthcare at Teachers College to identify meaningful relationships. Those I mentioned a little earlier, a bunch of new measures that I mentioned a little earlier on. So we try to get the correlation between adherence and some of these scales in terms of how African Americans perceive racism, what they think about it, how they respond to it. And here are some of the results. Some of them are pretty clear, but some of them I'll have to explain a little bit more because these are some of the scales that we use, the measures used from the research group at Columbia here. One was medication adherence and age, and I think this is pretty understandable that there was a significant positive correlation between medication adherence and age, which means the older the participants, the more likely they were to be adherent to their medication. I think that's pretty sort of intuitive because when you're a little younger, you may not think you need medication, you may feel invincible, but as you get older, there's more of a thought out process to make sure you do take your medication. So as age went up, adherence went up. 2, medication adherence and adaptive cognitive responses. Now, an adaptive cognitive response is when there's stress or there's racism that you see or you feel, you analyze the situation, you see the positive side, you say things out loudly or silently and calm down. That's adaptive cognitive responses. It's using things with your mind to analyze, see things, rationalize things out. And there was, in terms of the study, we found out that there was a significant negative correlation between medication adherence and adaptive cognitive responses, which means the more that participants use adaptive cognitive responses, the less adherent they were to their medication. Okay? And what might be happening, and this is just conjecture, what might be happening is people who analyze the situation, what caused this high blood pressure, what was the stress or the racism that I experienced causing the high blood pressure. When they analyze these things and see the positive side of things, they may not want to take their medication. They may want to rationalize and find out what happened to me, how can I find other ways to combat this stress or racism, and hence they will use less medication. Other results are medication adherence and annual household income. There was a significant negative correlation between medication adherence and annual household income. Once again, in this particular regard, the higher the incomes, the less adherence to the medication, which means folks who are, working long hours, had higher incomes, probably had good insurance, were less likely to be adherent to the medication. Whereas if you have a lower income and if you get sick and you miss work, you don't get paid, you're more likely to be adherent to medication. So annual household incomes, there was a negative correlation between that and medication adherence. Okay. The next one is medication adherence and a perception of racism, a perception of racism. There was a significant negative correlation between medication adherence and a perception of racism. This refers to the point that if a participant, one of their clients, whether you're a doctor, a nurse, or caseworker, counselor, if your clients perceive that you are racist, they will not listen to what you have to say. So if a doctor recommends a medication for a patient, or you recommend some advice for a patient, and they perceive that you are racist, they will not take your recommendation, hence the negative correlation. So when there's that perception there, they will not listen to the advice that you're giving to them. In terms of medication adherence, when the participants perceive that there was racism, they were less likely to be adherent to their medication. Okay? And I think that goes not only for medication adherence, but in anything else that we're trying to do in working with our clients. If there's a perception that they think you might be racist, your advice may be falling on deaf ears. So we need to make sure that even in our dealings with our clients, that even the perception of racism does not exist. 2 more, medication adherence and adaptive spiritual responses. There was a significant negative relationship between medication adherence and adaptive spiritual responses. An adaptive spiritual response is a person who will turn to prayer or turn to God or a spiritual source for guidance. So there was a negative relationship. The people who are more likely to turn to prayer, to turn to God, to turn to spiritual source, were less likely to be adherent to their medication. Once again, it goes to sort of people who feel that my faith, God's in control, things will take care of themselves, may be less likely to be adherent to the medication. And we as health educators, and like I said, whatever where you practice, whether it's a hospital, a caseworker, social worker, or just a counselor, need to take into consideration the differences in people. There are some people who, based on their faith, do not want to take that much medication. So you have to find a way to reach them where they are. I think like was mentioned a little earlier, it's not an A over B. You don't tell them what to do. You work with them based on their faith, what they know, and help them to get to the point where you can explain to them, it's okay to be spiritual, but if you have high blood pressure, then you need to take some medication. An example would be a person of faith who says, my faith, I'm going to pray about it, and my blood pressure might go away. You as a counselor, if you know where they stand, you know about their faith, talk about the faith and the works part of it. They have a part to play to reduce their medication, their hypertension. If the prayer alone can do it, by all means encourage them. If turning to a spiritual source can do it, encourage them. But if they're not controlled on just that, they need to take their medication and be adherent. The next one is adherence and health status. There was a significant positive correlation between medication adherence and overall health status, which seems to make sense that if you're healthy, you're more likely to be taking your medication. So adherence, which one comes first, we don't know. Whether you're adherent first and become healthy, or you're healthy because you're taking your medication. It's the chicken or the egg. But once again, people who have an overall health status are more likely to to be adherent to their medication. Okay, medication adherence and skills to cope with racism. There was a significant positive correlation between medication adherence and skills, adaptive skills, needed to cope with racism. So as an example, somebody who feels discriminated against, or who feels that there's racism, if they have skills, adaptive skills, they found ways to cope with the racism, whether it's by praying, exercising, laughing. They found ways to deal with the racism and tackle it. They're more likely to take their medication. Whereas somebody who cannot cope with the racism, who does not have those adaptive skills for the racism, may not take their medication. So the skills the adaptive skills, I think was mentioned earlier, adaptive skills, not getting angry, not blowing your top, trying to find a way to cope with the situation. Those types of skills reduce the blood pressure, and very often they help in a person becoming more adherent to their medication. Then there's medication and the quality of care. There was a significant positive correlation between medical adherence and quality of healthcare provided. Once again, when a client, whether it's in a hospital or like I just mentioned, a community health center, when they believe they're getting a good quality of care, that you really are looking out for them, you give them good quality care, they're more likely to believe what you're saying. And when you recommend something, in this case medication, they will take their medication. And I think that's very important in terms of especially physicians and nurses and those who are in hospitals, is that the perception that your patients or your clients have of you impacts how they take their medication or how they respond or follow through on what you tell them to do. If they perceive that you're racist, if they perceive that you're giving them poor quality care, if they perceive that you don't care, you will not get the medication adherence. And hence, you might have difficulty in convincing these patients to do what might be in their best interest. Okay, I think this is the last in terms of the results. It's medication adherence and adaptive behavioral responses. An adaptive behavioral response is when a person who is faced with racism or oppression, when they speak up assertively, when they talk with optimistic friends, or when they relax in a park or garden or an ocean, they take a behavior, they do something when they experience this racism. And once again, a person who is more likely to speak up when there's racism talk with optimistic friends to get encouraged or relaxed. They found a way to cope with this racism. And when you find a way to cope with it, you're more likely to do the things that are required for you, either to take your medication or to get better. And once again, people who don't speak up or who don't have those behavioral skills may be in a situation where they have talked to negative friends and have not found a way to deal with the situation. And in terms of listening to medical advice, taking medication or doing other things, they may not be able to take those behaviors. Okay, so what we did, we looked at a number of variables, and we picked out, we did a correlation to pick out the major predictors of medication adherence. Remember at the very beginning, we said medication adherence and has a key impact on health outcomes in terms of high blood pressure. So we wanted to see what are the key predictors of medication adherence. What types of either demographics or behaviors would lead to medication adherence? If we can identify what these are, if we can marry the two, we can increase medication adherence and then be able to reduce high blood pressure with high-risk African Americans. Okay. Here's what we found. One of the first indicators was not having a partner. And that might be a little counterintuitive because we think that when you have a partner, you're more likely to be adherent. The group that we studied was from an adult community center in Philadelphia. Most of the participants were older and they were females, which means over the years they may have lost their partner, maybe due to divorce or death. So these were older females who were very adherent. Hence the data may be a little skewed because the people we studied were a little older, because a lot of data suggests with a partner you're more adherent. But with this particular group that we studied, they were older females who did not have a partner and they were adherent. Hence we got this data that not having a partner is a significant predictor. Another one is not being employed. Once again, folks who are employed and may be running to work, doing so many things, may affect them taking their medication, right dose, right time, right place, because they're doing so many things, they may not have the opportunity to take their medication like they should. But those who are not employed, who are not going to work, could spend the time in the morning or in the afternoon or in the evening to take their medication exactly when it was needed. Better health status. Better health status. Once again, one of the significant predictors is people with better health status were more likely to be adherent to their medication. Once again, we don't know which comes first. Are they adherent, hence they have better health status, or the other way around? But what this suggests to us, once again, is if they're good, there's good emotional health, good physical health, good coping skills, that's likely to lead to adherence and taking actions that will help with high blood pressure. More skills to cope with racism. I think I touched upon this a little earlier. Those who have developed adaptive skills to cope with racism, whether adaptive cognitive skills, spiritual skills, those who have those type of skills are more likely to do something about their hypertension, and such as taking their medication. So there's a positive correlation between having those skills and taking their medication. The last two are less psychological disturbance, which means those who have a better emotional health, a better way to cope with the situation, the stress and the racism that they're facing. So they have less psychological disturbance, better emotional health, are more likely to try to do something with their high blood pressure, such as taking their medication. So less psychological disturbance was a predictor of medication adherence. And the last one is a fewer adaptive, behavioral skills. Fewer adaptive behavioral skills, which means we talk about adaptive behavioral skills. Those who behave in a way such that when they're stressed or racism, they either speak up, they go to a pond, they do something, they work for change. Those who have those skills, those who have those types of skills are more likely to do something about their blood pressure and hence take their medication. With fewer skills, fewer adaptive skills, don't speak up, don't try to either speak up, go to a place, try to get to a calm place, do yoga. Those are few of those skills may not have all the skills required to help them mitigate their blood pressure, hence may depend on medication a lot more. They have fewer skills to cope with their blood pressure, so they go to medication a little bit more than somebody who had some of these skills, who may exercise or go for a walk or speak up or do something along those lines. Okay? In conclusion, cardiovascular disparities are being reduced very slowly at best, and in some cases even getting worse. At the very beginning, I said very often when we talk about African Americans and having high blood pressure, we think, oh, maybe it's the insurance, it's diet, it's exercise. So there are many, many good theories out there and many, many good intervention programs out there. But if the problem's getting worse, we might be missing something. So I think part of what we're trying to do is bring some new and innovative ideas. If we can find out what are some of the behavior traits of people that will make them more adherent, if we can talk to them about their spirituality or their thinking or their behaviors, if we can understand them and find out where they are in terms of those types of behaviors, we may be able to relate to them better. They may listen to us a little bit more and be more adherent to the medication. If we meet them as partners and talk to them as partners, as opposed to telling them what to do. Patients no longer do not want to be told, take this medication, that's all you need to know, nothing else. You need to relate to them, find out what makes them tick, quote unquote. So if you can do that, you can relate to them, connect with them, they're more likely to listen to you and be adherent to the medication. So this goes to the second bullet, that there's a need for health educators and health education researchers to develop new and innovative programs to reduce disparities. And like I mentioned, the group on health disparities at Columbia University Teachers College has some of these newer skills that we use in this particular study, and these skills can help us identify the type of behavior traits that people have. When we can do that, we can relate to them better and help them with their medication adherence. It is a complex relationship between medication adherence and coping skills. But I think with the new skills that are being developed and with some of the newer research that we're looking into, that we can find a way to marry coping skills and medication adherence, hence help African Americans who are at risk do a better job of coping with racism and stress and oppression, and do a better job of taking their medications and reducing their high blood pressure, hence reducing health disparities. And I think that is my last slide. So, are there any questions or comments? Yes, please.
I have a question. When you were saying that if the provider perceives that the doctor or whoever is giving the medication to be racist, then there's less adherence,
Yes.
how, on your survey, how long did you determine that they were perceived to be racist? Was it fill-in or?
There's some of the, we have one of the scales is when racism and or oppression happens to me scale. It is a question that, do you know when it's happening to you? So, and in that particular survey, patients, clients, the participants were asked about these questions, and they would say, yes, I know what's happening to me. So it's one of those scales that I was just talking about, one of those measures I was talking about. It asked that question and a bunch of questions, and they said, yes, I know what's happening to me or happening to others. Okay. Yes, please.
You spoke about the overall correlation between medication and overall health status.
Yes.
Was it the perception of who determines the overall health status of the public?
One of the earlier questions after demographics was some of the questions that, where do you rate your health? How do you feel in terms of the specific wording in terms of how do you rate your health? Are you healthy? Do you think you have good health? Yeah, a Likert scale. You're very healthy, you're not as healthy. So the participants indicated where they felt their health was. Yeah, their perception. Yes, please.
Hi, very interesting presentation.
Thank you.
I got a little bit lost though in sometimes you had an inverse relationship between adaptive coping responses and medication adherence, and sometimes it was a positive relationship. And I and they may have been different kinds of coping.
Okay.
Could you enlighten me about that?
Sure. In terms of coping skills, overall coping skills, it is a positive correlation between coping skills and medication adherence.
Now we're talking about coping with racism.
Yes.
Okay.
Yes. Those who have the skills to cope with the racism are in different, whether it was adaptive, cognitive, adaptive, spiritual. Overall, you bring all these coping skills together. Overall coping skills, find a way to cope with the racism, were more likely to be more adherent to their medications. But when you break down to specifics in terms of you pull a particular one out, like spiritual, now they've an inverse relationship. But when you put them as a whole, overall coping skills, there's a positive correlation.
Oh, I see. There are types
Global
of.
versus subscale.
Right. Okay. Okay. Thanks.
Oh, you're welcome. Yes, sir.
Your data point to some insight in terms of implications for secondary prevention because you're dealing with individuals who are already hypertensive. What do you think, based on what you found, could be some implications for primary prevention in terms of dealing with and coping with racism among non-hypertensive?
Before folks become hypertensive, I think in general, one of the things that we can take a look at is in terms of just learning some stress management, some coping skills before we get to that point. I think it was mentioned earlier on, if something happens to you, do you get angry or do you lash out in terms of response? Those types of behaviors, people getting angry or getting impatient. I think Dr. Ross mentioned something this morning. I don't know the exact example, but those types of behaviors can prevent us from having high blood pressure. I think not very often, but in many cases, high blood pressure is a result of pressure, tension, stress due to either racism or anger or those other types of things. If we can try to begin to educate people in terms of using better coping skills for everyday problems, everyday stresses, that may prevent us from getting to the point where we have hypertension and need medication. Okay. Yes, please.
Just to piggyback off of what Professor G just said, I thought this was wonderful because for me personally, I have hypertension. And even though I do take my medication as I'm supposed to, and I'm trying to watch what I eat, and I eat, healthy and minus the salt and so forth. When you spoke of the racism, I never really put those two together because I go to the doctor and all they mention is, are you eating healthy? And I'm still eating healthy, but my numbers are still high. And dealing with racism and different things that I encountered at work and, other stress-related things, now I'm kind of like realizing that that's the reason why my pressure, is still because I'm eating right. But because of the stress of these other things, this is what's adding to keep my numbers up high. So this was enlightening because I'm trying to be more spiritual.
Good.
And things to bring it, calm myself and bring it down. But it's hard. It's shocking to see that.
Yeah.
It's not the greasy foods and because that's all they keep saying is, are you still eating fried chicken, macaroni and cheese? Are you watching what you eat? I'm like, yes, I'm eating some. I haven't had anything because of the stress.
Good. And this bears out what we're trying to do. We're trying to make this part of to add to the intervention. Yes, there's a medication. Yes, there's the greasy food, to use your words, and there's the diet. But there may be some other things involved that are going on that we need to take a look at. And if we can find ways to work on those other things in terms of coping skills, that may go a long way in helping us have better health outcomes.
So could you just go through a list, just identify 5 implications for someone just like her?
Okay, let's see, 5 implications. Okay, one of the things that you could do, I think you said you're trying to be more spiritual. So that could be one in terms of looking either inside or looking for some divine source. If you're a Christian or if you're a Muslim or if you're of the Jewish faith, look to your faith as a way to deal with problems that it will get better. That could be one of them. Behavioral responses. One of the things that you could do in terms of behavior is speak up assertively in cases where there's racism. Talk to positive friends. You could do that. Go to the beach, take a walk. Those types of things. That could be something you could also do as well. Cognitive, in terms of when you do experience, some racism that may be pushing up your blood pressure, analyze the situation, think about it. Okay, what happened here? What can I do next time? How can I make changes to avoid that situation that just created this anger, my being upset? So that three, how many?
Examples of how to look at it differently. For example, acceptance.
Okay. So, okay. Certain things are going to happen in life, and we can't control every single thing. We try to control as much as we can. Certain things we have to accept and find alternate ways, I guess, to deal with those particular situations. It's going to happen. This is going to happen. I need to accept it and find another way to cope with it. I can't fight this particular thing. This is a wall. I need to accept it. Me try and find a way to go around the world, over the world, underneath it. Accept this particular situation, which I cannot change, which I'm not going to knock my head against all the time because it's not going to change. I'm going to accept this particular situation and find other ways to get around it. Okay. Well, if there are no more questions, thank you very much.
Okay, why don't you stay there for a moment? I'm extremely proud of you. Of course, I'll mention you so that you changed just a few things in your language which were kind of related to the question I think you had from the back. But I now see why you were determined to become a professor and to leave your lucrative pharmaceutical employment. Because I think that I am just so glad that I had this opportunity to hear you elaborate. You know, when you have an oral defense of a dissertation, they say, could you please just talk about it in 7 to 12 minutes? And so you never get an opportunity to really hear this kind of elaboration, which is what was so wonderful about hearing Shayla's presentation. I mean, here Shayla said, I'm talking about my dissertation. Oh, no, no, no. She was talking about focus groups and interviews that she conducted that were technically even before her dissertation. And so I'm just so proud of both of you that you really had this opportunity to go into detail. And both of you, well, I mean, in terms of you, Dr. Daramola, it's just so exciting to see how when you got released from that pressure I had you under, with my foot on your back,
Yes.
and you have really blossomed.
Thank you.
And it's just really a pleasure. It's such a reward to see that the stress involved in pressuring someone and pushing someone to reach their highest potential. Then you say bye-bye, and then they just keep on reaching their highest and highest potential. So it's just so gratifying. And I look forward to Shayla just taking off like a rocket after May 2009. And we have to give, now I know he's Dr. G. They figured out how to deal with his long last name. He's now Dr. G, our other recent graduate, who we really have to thank and honor for putting such an effort into bringing out the most undergraduate students, to expose them to mentoring. And we'll say that Dr. Daramola is a close second in having students from BMCC. So let's just thank them because they have really enriched our conference by allowing us to mentor individuals as early as their undergraduate years.
The preceding program was brought to you by Teachers College, Columbia University. Please visit us online at itunes.tc.columbia.edu.